I'm going to record. Okay, good afternoon, everyone. This is Travis. I'm filling in for Jeff this week, and we're going to start with Howard. It's a small group right now. Hopefully, we'll have some more people join.
Alrighty. Here's a really interesting case of acute aortic syndrome. So here is the initial series that the patient came to our hospital with a diagnosis of acute aortic syndrome. I don't have a non-contrast series to show you. Sorry about that. Let me just get back to what I was trying to do. So let's scroll through the type B acute aortic syndrome and appreciate how much abnormality is located in the wall of the aorta, particularly in its medial aspect, certainly consistent with an area of blood. I suspect that if you had a non-contrast, that this would be relatively hyperattenuating. Let's see, ounce-filled units here is in the range of their 80-ish ounce-filled units at that level. So I'm going to put up the coronal, and now I'm going to put up alongside a follow-up exam. Now the follow-up is only 4 days later. I'm not sure exactly why they chose 4 days or what the intent of this was, but let me put this up alongside, and you'll see in a moment what happens after 4 days. So let me go to about here on the initial one, and now we'll scroll through this one. So first of all, check out the relatively large intermedial breach, if you like, or a little fenestration that's developed right up there. Now, at that particular point, there was probably a little, not a breach, but a little point right there. But you can see there that the breach is developed. It has a neck of this kind of dimension. And notice how the contrast goes up the false lumen or the wall of the aorta superiorly, quite a ways, like that, up. And then what's really interesting is that lower down, as I scroll lower down, you'll see other ones just hit. You'll see them appear right here and right there, and a bunch of them. Let me put up the axial alongside to give you a feel for that. So again, this is on the 9th. I'll put up some thin cuts for you and show you what these look like once more inferiorly, and how the contrast in the short period of time moves around in the false channel, or at least in the wall of the aorta. So that developed just in a few days. Now I'm going to bring up alongside here, particularly with respect to these on the medial side, a description of so-called intramural blood pools that form. Let me put it over here. So this is from an article, and I'll show you this in a moment. But the idea is that these medial collections are a result of disruption of the intramural portions of the origins of branch vessels, in this case intercostal arteries. And as these branch vessels are disrupted, there clearly is pseudoaneurysm formation. And then if you look over here and you see the contrast-opacified blood coming into the wall, it may go a certain distance, of course, just reflective of how much time we scan it. But what I really like about this particular concept, and here's the article, the parent article, that is a really nice description of this phenomenon. is that they make the comment here towards the end of the article, and I'll mag this up, that they were predicting quite correctly that as scanners got faster and we have great spatial resolution, that we're going to start to see, as you see here, that these branch artery origins will start to become visible. And now check out this coronal, and you can see that a lot of these blood pools are absolutely continuous with little intercostal arteries that come right off them. So I think we definitely have that phenomenon occurring in relation to the intercostal artery origins at a couple of levels there, and demonstrated on the CT very nicely. So we have the larger ulcer-like projection, and then the small blood pools and pseudoaneurysms. And I think this is one of the better ones that I've personally encountered of this phenomenon. Any thoughts?
Yeah, agree. And then one comment there, one of the subsequent articles, because that was just part one, that one you're showing there. This is the one from the group at Michigan, correct?
These guys are from, yeah.
So they did 3 or 4 parts to this, and the final one they did showed that these branch artery pseudoaneurysms didn't have a negative effect on outcome treated conservatively.
Right. They didn't treat this patient. They're just, they're actually going to discharge this patient, even though we can see sort of an active process occurring over a couple of days here. And the amount of blood in the wall of the aorta is a little bit increased from the scan a few days earlier. But yeah, they managed them conservatively, even with a fairly dramatic finding here. Well, it's kind of dramatic on the CT in a way.
And if you have a 3D or a MIP, that's been called the Chinese ring sword sign, if people are into signs.
Yeah, if you have a bunch of round things all coming up and down the side of the aorta.
Chinese what?
Chinese ring sword sign. I think on a Chinese ring sword, on one side of the sword, there are all these round kind of structures that make little circles, rings.
So yeah. Signs aren't very helpful if you don't know what the sign is named for. So this is a new one for me. I'll just go with pseudoaneurysms, but I think that's a way cool case.
Yeah. Yeah. David, I just posted a link to a bunch of pictures in the chat section of GoToMeeting. But you're right. Yeah, signs are only useful if you know what they're talking about in real life.
Yeah. Yeah, so this is a lovely case of that. Alrighty.
Howard, I don't hear any audio. David, can you hear him?
No, I cannot.
Display.
So Howard, we missed your audio. Can you start over?
Your audio dropped off.
Okay, so this is a CTPA for PE. There is no PE, but what was described was bright pleural fluid, and I'll show you a couple of lymph nodes in a moment. But what was not appreciated is that this isn't just pleural fluid. So definitely down here, the appearance and the attenuation is that of fluid. But wasn't really appreciated is that when you get higher and you begin to look at the lateral chest wall here, the attenuation of the opacity here is greater than that of the fluid down here. And I also want to show you that in a few places like here, and I'll zoom this up, there is a little displacement of the extrapleural fat. So we have the so-called extrapleural fat sign. That indicates that external to the displaced fat here, and it's subtle, the tissue here is extrapleural. And then you see that a little bit more up higher. But this tissue here is not that of just plain fluid, and we have the extra pleural fat sign. That indicates that the pleural here is very abnormal. It's thickened by tissue. So we have that finding. And then the other findings I mentioned were a couple of lymph nodes that were seen, but not too much was made of those. So up here in the axilla. But clearly, if you decide that the pleura is very abnormal, then the pretest probability that those lymph nodes, even though they're not huge, are also very abnormal increases substantially. So we don't have just a simple right pleural effusion.
Yeah, and
so
you have
fluid
soft tissue that's surrounding the internal memory vessels on that slice as well. Yeah.
Right. Yep. I'll tell you that the pleural fluid was removed, diagnostic tap was done, that did reveal abnormal cells, and I'll show you that in a moment. But I'm going to show you the PET here, which is pretty dramatic because it shows the extent of the pleural disease very dramatically. So you'll see it's super abnormal, as well as, of course, the nodal disease and the extent of the nodal disease. So this is lymphoma. There were abnormal lymphocytes in the pleural fluid suggestive of a lymphoma. Subsequently, one of the axillary lymph nodes was sampled under ultrasound guidance and also revealed the lymphoma. So this turns out to be let me have a look at it there, a nodal large B-cell lymphoma, as you see there. So a pretty dramatic case of pleural disease and nodal disease in this case, as you can see there. So you kind of have to watch out and not go through the pleura too quickly. Otherwise, potentially miss the extent of the abnormality. So that's a lymphoma.
I think it also illustrates one of the pitfalls of pulmonary embolism imaging, and it's one of my big pet peeves when you have pleural abnormalities, is the early arterial phase doesn't give it enough chance to enhance. If you had done, but if a later phase had been done, or especially if you have basilar pleural abnormalities and subsequent abdomen and pelvis CTs are done, it's always important to look at the more delayed imaging to really see nodules that enhance or abnormal thickening.
Yep. So I sent this case to some of you folks out there, but I'm going to show it to the audience as well. So this is an incidental finding in a patient. Even the CT PET was done for evaluation of prostate cancer. It isn't an FDG PET, but it's another radionuclide for evaluation of prostate cancer. So what I'm going to show you down here is the incidental finding. And let me actually bring it up with thin cuts and at a bone window to show you what I'm calling rocks of bone. So this is a pretty dramatic case. This is an incidental finding. And those of you that have seen this certainly, I think, agree that these are pieces of bone. We see trabeculae of bone, sure looks like bone. They're very discrete bone. And I don't know what this is. So I'm just going to put up alongside an invitation to anyone watching. That is, if you have any ideas about this case, if you've ever seen anything like that, or have any idea about the potential genesis, let us know, because none of us know what this is. It's kind of a fun case to look at, but certainly I don't think any of us have seen this and don't know what that is.
Howard, I think I could blow right by this and just say this is a normal wrist.
So yeah, it's kind of cute, whatever it is. So if anyone has seen that and you happen to be viewing the video on the STR channel, shoot me an email. Particularly if you have a case similar to this, that'll be kind of cute. So an interesting case of something fairly benign. All right.
The bone formation in amyloid does it. I mean, it's well corticated bone. It's big pieces like that. It really looks as if it thinks it's some other organ.
Yeah. Here's a nice case. The history is important here. This is a young person. He developed symptoms and ended up coming to the hospital. in the context of a hike. So he went up here in Utah. We have one mountain range called the Uinta Mountain Range. He went up to the peak, Kings Peak, which is the highest in Utah at 13,000. And somewhere on the way down, he started to not feel well. He was actually descending, and he wasn't feeling very well at all, quite short of breath. So he came into hospital with this radiograph. No alternative explanation other than HAPE, high altitude pulmonary edema, could be discerned. And you'll see the next day he is getting better. He was discharged. So by virtue of the context and the appearance, high altitude pulmonary edema is our diagnosis. It's a strange pattern. I've seen various patterns of it. I have no idea why it's so focal, mostly in the right upper lobe, left perihilar, looks like consolidation. I think without context, of course, you wouldn't know what this is, but undoubtedly a case of high altitude pulmonary edema.
Howard, how old is this man?
He's young, so I can tell you that right now. He's in his 30s, I think, 32.
32.
Yeah.
So evidently it's a disease mostly of young people, and they're often fit. It's not edema because people have weak hearts, a heart failure, and it's thought that actually healthy young people are more at risk, probably because they have more blood circulating to the lungs, and they have probably better vasoconstriction reflexes. See, the theory I had the last time I encountered this was a theory I was told was that these people are encountering this hypoxemia. The body thinks that the lung is not being well ventilated, and so it starts shutting down parts of the lung circulation with vasoconstriction, and then that over circulates other parts that are still receiving blood flow and stuff like that, and then it overwhelms those with the circulation, and that's how you get the damage to the walls and the leak of fluid. So it's probably people with the brisker reflexes, the vasoconstriction reflexes are healthy, and that's what predisposes to its being worse in healthy people. I don't know whether that's the current theory or not.
Yeah, I'm not really sure. I think that the underlying basic mechanism is thought to be acute capillary hypertension and stress failure of the pulmonary capillaries, so a form of acute lung injury edema. At least the endothelial cells are broken. And I think the injury just randomly can be very heterogeneous in the pulmonary vascular bed. And the cases that I have all look different. Some are asymmetric, some are diffuse. But most of the time, the amount of interstitial edema, if any, is very little. And they tend to present with alveolar edema consolidation, but sometimes a bit of both. But everyone that I have looks different. And they're always a little heterogeneous. They're never uniform, bilateral, diffuse.
That's really cool. I've only read about that and never seen it.
Yeah. Let me show you this one. It's cute. All right. So I'll make this up just for fun, perceptual sake. Take a look at that for a few seconds before I give you some context. The findings are really subtle. And as you look at that, I'll give you the context. This is a person that is a football player, and he went to our orthopedic hospital after he was tackled on the field, or at least involved in a tackle, crunched. He was crunched and subsequently developed chest pain. But that is the context. It was a football injury. So the finding is subtle, but it's pneumomediastinum. So I'll just zoom up a little bit. And there's a little bit of air here. And there's also a little bit of air right in here in the subaortic mediastinum right there. So pneumomediastinum is the finding. With that history and that information, an orthopedic colleague who happened to be working at the orthopedic center, I'm not sure quite why he went there, because I don't think he had any fractures. We talked about it and we decided we're pretty confident this was the Macklin phenomenon. So the idea being that he was probably squeezed or crunched between some other players. As his chest was compressed, his glottis happened to be closed. He had an acute rise of alveolar pressure, the Macklin phenomenon, and got a little pneumomediastinum. So he was then sent to the ER, which I think was a mistake because they got really concerned
Howard,
about him.
can you, before you go to that, can you show the lateral?
Yeah. Let me bring up the
it?
lateral for this and bring it down and see if we
Are
can
there any
see
good
anything.
clues on the lateral? Boy, it's...
No, you know, looking for like a air around an artery or something.
Right, or the anterior wall of the
Oh,
trachea. Yeah,
no,
I don't see anything.
It's all really just paracardiac. It's really, can't see it there. So he did get imaged with CT, and you'll see, of course, we confirm that he does have pneumomediastinum. It's a modest amount, and you can see, at least at this time, there's a little about the heart, and there's a little bit here in the mediastinum. What I did look for were signs of interstitial emphysema, like septal emphysema, or air within the peribronchovascular connective tissue sheaths, to even be more sure of the diagnosis. He doesn't have it, I think. He obviously had it at some point, but it's not there anymore. But they insisted on doing a CT with contrast medium because they said that he afterwards started vomiting, and they were really concerned about his esophagus. So we did what they asked. He doesn't have any injury to the esophagus. So football player, Macklin phenomenon, and I'm sure he'll do fine. And he did fine. Okay, I'll stop there, Travis, and show more if you want me to. Otherwise.
Okay. David, do you have any ready?
I do.
Okay, give me 1 second and I'll make you the presenter.
So here's a person who had a catheter placement, and it seems to cross the midline from the subclavian vein on the left and then hook upward. And anytime we see a catheter hooking upward, typically a little bit lower than this, but hooking upward, we're suspicious that it could be an azygous vein. And on a lateral view here, indeed, it is heading posteriorly into azygous vein. But this is not just any azygous vein. This is azygous vein in an azygous lobe. So this catheter has actually gone into the azygous vein, which is out here in the lung. Here are the 4 layers of pleura of this small azygous lobe. And on CT, here's the catheter crossing the midline in the brachiocephalic vein and then extending into the azygous lobe here, the vein in the azygous lobe. And this is the 4th case of this I've seen. So, you know, you think this would be a rare event, but maybe with this, with azygous lobe, the origin of the azygous vein is a little bit higher and maybe more of a straight shot for the left brachiocephalic catheter entering it. It seems to cross the mediastinum and just be headed right for this thing. So maybe this actually predisposes to getting a catheter into an azygous vein by the lateral and upward displacement of the azygous vein. So kind of cool. And then here's a right subclavian port catheter that's following a conventional course into the superior vena cava. Okay.
Very nice.
Now, here's a person who has a pretty normal chest radiograph, a little bit of basal atelectasis. Down here, nothing special on lateral view, slightly low lung volume, and had this.
Before you show anything, can you go back to it 1 second?
Sure.
Is there potentially something we might be able to see? Because I'm wondering whether the pulmonary arteries are distended. I'm looking at the main PA, left and right PA. I'm looking at a couple of pulmonary arteries on end.
Right.
I'm trying to decide whether pulmonary arteries are dilated. I don't know if I'm right about that. I don't think I see dilated pulmonary veins.
Okay. There's a little rotation. I think the left pulmonary artery may be standing up because of this rotation. So, and I was trying to see if this person is truly standing. I think the person is truly standing. So, you know, if this person were in bed, we could have this degree of vascular distension. You know, as phenomenon.
Yeah.
So I'm not sure about that.
Okay, maybe false positive call.
But
okay.
I'm glad you're alert to vessels, because here's what the CT looked like on this person, and it caused some misdiagnosis here. So we do have a vessel leaving the descending aorta here and heading out into lung. Okay, and so we should look to see if there's anything that goes with sequestration, because that would be great. Instead, what we have is extra small vessels here in excess number. So it looks as if there are a bunch of extra little vessels here that weren't on the other side. And that's probably because we've got systemic artery pressures here perfusing the lung, and so we probably enlarge some of these otherwise small vessels that wouldn't show up, and so we have a larger number of vessels because we've got this increased perfusion going on down there. Now, there's not an arteriovenous connection here, so it's not AVM, and it's robustly not sequestration, because notice the airways. We've got a normal complement of our airways in this region, rather than isolation from the airway system, which is where sequestration gets its name. It's sequestered from the normal airway connections. This person has robust airway connections in this part of the lung. Matter of fact, maybe there are too many of them. I mean, that seems like a lot of little bronchi. But at any rate, it's not a sequestration. So this is systemic arterial supply to the left lower lobe, but not sequestration. And I think we're seeing extra lung vessels here because of the higher pressure that's driving the perfusion down there. And I don't see any abnormal veins here, so this is probably draining to normal inferior pulmonary veins per usual. So it's not an AVM, and it's not sequestration, it's systemic arterial supply to the lung base. I see this more often on the right than the left. I don't know whether that's your experience as well. So it's an isolated congenital anomaly here of systemic arterial supply to part of the lung. And here's what it looks like on coronal. Again, I think you see not the world's sharpest coronal here, but you see an excess number of small vessels down there reflecting this, I think, higher pressure perfusion than normal.
Was this just an incidentalloma?
Yes, I think so. I don't know what drove the CT scan, what the symptoms were at the time. So I haven't researched this case fully.
Can you go back to the soft tissue windows on the axials, like the level of the atria? Because it almost looked like there was a sinus venosus ASD, but it may have just been motion, because I was kind of attuned to what Howard had been saying about the vascularity. No, I think it's just motion. Okay.
I don't just go to the coronary sinus. It looked maybe a little bit. Was the coronary sinus dilated, or something unusual about coronary sinus?
Like right in there, actually. Is there a large secundum atrial septal defect? Look how large that right ventricle is. It looks like shunt vascularity. And then in the mid, it was actually a little bit lower in the septum, not the sinus venosus, but it looked like the mid interatrial septum. You just lose
that's right
there.
Yeah, you're absolutely right. There is an ASD here. Yeah, and that was part of the diagnosis too. That was mentioned in the CT report. So I think it's a secundum ASD.
Okay.
And that was also documented echocardiographically too. Yeah.
So this upholds Kanne's law.
Absolutely right. The vessels were juicy, and there is I think there was mild pulmonary hypertension, if I recall the echo correctly. I'll clarify that when I post this case. But the central pulmonary arteries here, this is big. You were absolutely right, and the left pulmonary artery is big too. It wasn't just rotation; it was real.
Yeah. But it follows Kanne's law. Then we have two congenital abnormalities with the systemic arterial supply and the ASD.
That's right. Kanne's law rocks. It totally rocks. Okay. So Howard, apropos of a case you showed last week with a subtly widened mediastinum, elongated, subtle widening of the mediastinum, this case popped up. Yep. So mediastinum. What do we think?
Okay, so let's have a look. There is an interface in the azigoesophageal recess which may represent a distended azygous vein going upwards, perhaps.
Mm-hmm.
And is that gas in colon, or is it potentially a stomach on the wrong side? I'm just looking at things. But there is something in the azigoesophageal recess, I believe.
Yeah.
The interface of the azigoesophageal recess projects too lateral relative to the spine.
Right, it's very sharp.
Up and down, but it's too much to the right side. The actual azygous vein up higher doesn't look that big, but there is something related to. And then, is there something odd about the trachea? Does it narrow a little bit?
Yeah, that's
And
what I
if
was
so,
wondering
why?
too.
Through here.
A bit narrow, segmentally. So let's see what else.
I wonder whether this, when I first saw this, I thought it was something aortic, you know, and because the trachea seems to be affected, and I thought, could this be some sort of a vascular ring? And but we seem to have a good descending aorta on this side, so this would, if there were two descending aortas, that would be unusual.
Even above the aortic arch, it almost looks like there's too much soft tissue that's displacing the trachea rightward.
Yeah, sometimes you'll see, you know, an aberrant right subclavian do that. So yeah, I was thinking something aortic when I first saw this. Okay, shall we proceed?
Great.
Lateral. Does the lateral help us here?
It doesn't help me.
Hilar anatomy there. Good looking distal aortic arch here.
No mass effect on the trachea, either front or behind.
Ready?
Very good.
Okay, so we do have aberrant right subclavian. And then we have very dilated azygous vein. And that dilation continues downward. We get into the abdomen here, and then all of this blood comes from the inferior vena cava. So inferior vena cava shunts blood to Mr. azygous vein here, and then we lack a cava for a while, and then we have a confluence of hepatic veins to form a small cava here of just hepatic veins meeting the right atrium. So this is azygous continuation of interrupted inferior vena cava. Here's the stomach on the right, and notice the distribution of liver here. It's got a big component going way off to the left here, and there's no spleen that I could find. So this is asplenia, transverse lie of the liver here, azygous continuation. This person has some situs issues. Now, is this spleen over here?
It looks like spleen there.
So
it might be a linear type spleen.
Okay, so the spleen's not doing what it's not in the place it should be, and I don't know about the gut, whether the gut is malrotated here too. Okay, so I guess it's not asplenia if the spleen's over there, but this person has too much right-sidedness, I think.
With the airways, I was going to ask. It looked like when you were showing the main stem bronchi there that they look fairly symmetric.
But we've got a left pattern here with a pulmonary artery going over its bronchus here, correct? And the right PA is in front of the bronchus, not going over the top of it. So we seem to have conventional proximal anatomy there.
But we do need to count lobes and see how many lobes.
But we don't seem to have. I think this is still just the upper lobe bifurcation there.
Yeah, I was wondering if it was going to end up being bilateral left-sidedness.
But the pulmonary artery is not going over this bronchus, so it's not left isomerism, because this is the pulmonary artery is in front of, not over the top of the bronchus as it is on this side. So on the left side, the pulmonary artery goes over its bronchus. When you have left isomerism, the right pulmonary artery will also go over its bronchus. But what we don't have is we don't seem to have an upper lobe coming off promptly here. I mean, it seems to go a long way before it branches. So that is another anomaly. Now, is this the right upper lobe bifurcation there into? It's not. So the bronchial anatomy is messed up here. Let's check it out on coronal.
Looks like we have two lobes, maybe just two lobes.
So in this sense, it does imitate a left lung in terms of having a long, very long, unbranched bronchus. And
yeah, that's right. It does.
A prompt upper lobe, but it doesn't seem to have the usual pulmonary artery relationship with bronchus that I've seen in other cases of left isomerism. But it's
David, the pulmonary artery on the right.
I'm sorry?
The pulmonary artery on the right. The pulmonary artery on the right is going over that bronchus, so that is an additional hip arterial bronchus on the right.
Let's check it out on lateral. So here we are on the left, and here is left pulmonary artery going over its bronchus. Okay, let's continue across the mediastinum, which I think I'm doing here, and I see right pulmonary artery, and it doesn't actually seem to go over the bronchus in quite the same way. But the bronchial system is messed up on that side.
It is, yeah, it's so.
And it does have some relation, some imitation of a left bronchus in terms of having a very long unbranched bronchus and not a clear upper lobe. And we should count the lobes on that side too. Let's see how many lobes are going on the right. So I think we're in right lung here, and I'm only seeing one fissure here. I'm not seeing a minor fissure. So that's left-sidedness.
Yeah.
Too. Okay. So it's, I think it's done a sloppy job of trying to be a left lung. It's not quite got there.
But the combination of findings, two left lungs plus the polysplenia, and the other findings go along very nicely with
polysplenia rather than asplenia. Yep. What I first thought.
Right.
So the polysplenia with abdominal situs further messed up and putting the spleen off on the left and everything like that. So,
and as it was continuation of IVC, part of that entity, everything, yeah, now fits quite nicely, I think.
Okay, so three cases of congenital thoracic.
It's great.
Fun conditions.
Very, very nice.
Do you have any others, or is that it, David?
That'll do it. I'm worn out.
All right.
Good job.
Those are great. Okay. You see my screen?
Yep.
Okay, Howard, I'm glad you showed the one case that you did of lymphoma in the right pleural space. This is a man who came in with right-sided chest pain to an outside hospital back in May, as you see here. And he has this soft tissue encasing his right internal mammary vessels. Looks like a big right internal mammary lymph node or something, soft tissue mass that also extends out through the chest wall here. And I think this was where the source of his symptoms were. But of course, you can see here that we also have this just soft tissue conglomerate that encases the aorta, encases the pulmonary artery, encases the coronary artery. So this is one big confluent soft tissue mass in the pericardial space and extending into the mediastinum. He underwent a PET at the outside hospital, and I'll show it to you only because, unlike your case, this one's not nearly as impressive in terms of the amount of metabolic activity. Certainly there is some, but it's not, I had to window it quite a bit. It's not that much higher than blood pool, and the stuff in the pericardial space and surrounding the heart is really not that impressive at all. So he underwent a percutaneous biopsy that was non-diagnostic and then came to our surgeon, and they did a surgical biopsy of this right internal mammary thing. Part of the reason I think the original biopsy was non-diagnostic is they weren't suspecting lymphoma. And of course, that was the first thing I was suspecting, as I'm guessing you were too, especially after seeing the other case. But what is surprising is that this has been discussed at Tumor Board now 2 weeks in a row. They did an excisional biopsy, and it was about a 2-centimeter chunk of that right internal mammary soft tissue mass they got. And this is all they got was a bunch of collagen and then this fibroinflammatory stuff. And we even specifically raised the possibility of IgG4, only rare positive cells, as you can see here. And so the jury is still out on what this is. The pathologist said this might be an inflammatory lesion, like a plasma cell granuloma variant of inflammatory pseudotumor. I'm not as crazy about sclerosing mesenteritis or mediastinitis. Like, it certainly doesn't really behave like that. I kind of am still dubious. I'm curious what you guys think, because I'm wondering if this is still not just a lymphoma that they're not really getting a good sample of. I'm curious if you guys have any opinions, because that's sure as heck what it looks like, more so than I guess these other things possible that I've never seen them look like this.
So can you go back to the original CT and tell me what sort of attenuation was in that, the anterior mass in the in the chest wall there?
This one?
Yeah.
Yeah, you can see it looks like it's going to be in 40, 60.
43.
Yeah, and this stuff's in the 50 to 60 range, 40 to 60 range. Yeah. I mean, were you thinking some sort of pseudotumor then, or? Yeah.
Well, there was a case that we had with a CT scan 2 days ago that had a similar looking chest wall lesion to this, but it was a little more spherical, and the attenuation in it was 27, and there was one little piece of calcium in it. And I was thinking it looked more like a myxoid sarcoma or something like that.
Yeah.
You know, not a chondrosarcoma with a lowish attenuation. But so I was just curious to see whether I should have considered lymphoma as based on lowish attenuation. So
yeah,
it's like this.
And Howard, I don't know, maybe if you could look at your case, what was the attenuation of the soft tissue in your lymphoma? Was it similar? Because this is kind of along the lines with, you know, a little bit more maybe than most muscle, but
yeah,
I don't know. I think that, does anybody disagree with the idea that they should get more tissue in this case? Because I'm certainly still dubious of this kind of non-specific diagnosis.
I wonder if they did or something like that, because we've seen cases of mediastinal masses with, you know, big bulky masses, and they didn't find any lymphoma until they looked really hard, and then they found a few, like you know, Reed Sternberg cells or something like that, driving this proliferation of a whole lot of other tissue. So I would, given a big bulky soft tissue mass like this, I think lymphoma is top of the list still.
Yeah. And we've shown many cases of pericardial and cardiac lymphoma too. So yeah, I think it's, I don't know, I'm still suspect.
Is this infiltrating the heart muscle and encroaching on the lumen, or are the lumens okay? They're okay.
I think they're okay. I think it's more just along the kind of the base of the heart near the root of the aorta and a little bit into the interatrial septum perhaps. But yeah.
Yeah.
That's also good for lymphoma.
Sure.
Info like that.
Yeah, like, yeah, in the interatrial septum, and just kind of extending it, because it does look like more of a soft tumor, just encasing, but not really. I think these coronaries are a little narrowed, but they're not severely compromised. And so this, by the way, was a follow-up CT that was done, I guess this is yesterday, that still pretty similar, other than just the surgical appearance from them doing an excisional biopsy in this area. So it really hasn't progressed that much in a couple months, but I still don't think that dissuades me from this being potentially lymphoma still. So
yeah, I think
curious one. All right, let me find the right one. Two related cases, a little bit more, you know, standard stuff, but just pretty examples. This is a 38-year-old man who has a history of asthma and came in with some cough, and then I'll pull up his report here too, but also had some drenching night sweats at one point in time. And I think that you can see on this, he's a fairly thin guy, and we see some upper lobe peripheral, fairly symmetric areas of linear, like bands of consolidation, maybe a little bit more ground glass type opacity peripherally here. And he was treated with antibiotics at an outside hospital, and then eventually transferred here, and where we, you know, suggested the diagnosis, and the diagnosis was eventually made of a chronic eosinophilic pneumonia. And you can see, nice example, I think some little atolls, and fairly symmetric. Here's another atoll in his upper lobes. And then he was eventually just checking his CBC, and you can see his absolute eosinophil count was elevated. So he resolved after starting on steroids. So this was the first CT, and then they got a follow-up CT about a month later, or just under a month later, after starting steroids, and you can see that the findings have almost completely resolved. So that was, just a pretty run-of-the-mill case of eosinophilic pneumonia, chronic eosinophilic pneumonia. And I want to show this one because this is one that Brett Elliker showed me a couple weeks ago. Similar symptoms. The scout image, and maybe there's a radiograph, looks pretty similar, a little more subtle on this radiograph. But I like this one because the CT, this is after treatment actually, this radiograph, but the CT is quite impressive in terms of just how pretty this looks. And you'll see you have these nice bands of consolidation, and then it's almost like the crest of a wave, and you can see all of the ground glass peripherally going out to the edge of the lung. So this was another case of chronic eosinophilic pneumonia in a 16-year-old woman, but it's one of the prettier examples I've just seen of this. And was it last week we were talking about the phenomenon of, or Seth was asking the question of why things heal, the way they do in organizing pneumonia? Weren't we having a discussion about that at some point?
That's right. They heal from the center outward, and they leave you stuff along the edges of the lobules.
Yeah, but I just thought this was a really just gorgeous case of atolls in somebody with chronic eosinophilic pneumonia. Now,
is this after treatment, Travis?
No, this was not after treatment. I think this was her initial study, and I don't even know. I think this was later on in the course. This was, as you can see here, this was almost a year later. So she still has some abnormalities, but this was a little later. And she just recently was referred to us to our interstitial lung disease clinic. And she'd had 1 to 2 years of intermittent coughing. And interestingly, somewhere they had diagnosed her with chronic hypersensitivity pneumonitis and then given her multiple bouts of steroids. So I don't really know the true time course, but I think that original study was at her time of diagnosis. And she was also one that had eosinophilia both on bronch and peripheral blood. So I show those two. I want to revisit this. I've shown this case before, but it's an almost identical pattern in a different distribution and a different context. And you can see here that this is another woman, and I've saved this case because it's, again, one of my favorites, but you can see just the same peripheral, these atolls with just this nice band of consolidation that works its way outward, and then you have ground glass opacity here. And this one is more lower lobe predominant. It's more uniform in distribution. She's got a little bit of traction in the lower lobes. And this is a patient with a connective tissue disease. And this was more of a mix of NSIP and organizing pneumonia. And so probably the organizing pneumonia is in response to the lung injury and the NSIP. But it's the same type of phenomenon with lung injury, just from a different cause. But very similar appearance, very symmetric, just in different lobes of the lungs and different distribution from a different underlying abnormality. I don't know.
That is so interesting. I don't think I've seen that pattern quite dramatic before. That's very impressive.
Yeah, and she's one that here you can see her surgical lung biopsy. So it's NSIP and organizing pneumonia. So of course you think connective tissue disease. She has, I don't know if she actually has a diagnosis. She does. Okay, so she has scleroderma, because otherwise she'd be interstitial pneumonia with autoimmune features or some sort of undiagnosed connective tissue disease. But she had, I think by this time, manifest with criteria that met a diagnosis of scleroderma. But yeah, this is, again, one of the prettier cases we've seen of an NSIP that I was reminded of when I saw that other case of eosinophilic pneumonia.
Very impressive. Wow.
And let's see. We will go on to this one, I'm curious. This is an interesting case for a couple different reasons. This is a story that started a few months ago. This is a patient with relapsed AML and came in. They were diagnosed at some point in time, and you can see she already has underlying abnormal lungs. This is back in February. She has some bronchiectasis. And I don't exactly know why, because I don't think she had graft versus host disease or had a prior bone marrow transplant at this point. So I don't know if she just had prior pneumonia or had some other underlying abnormality that was the cause of her little bit of bronchiectasis and bronchiolectasis that she has. But that was February. In March, she came in, has a small effusion, and has this peripheral area of consolidation, and she's neutropenic at the time. And so this looks like a small bird's nest, I think, as we would describe in some of these cases. Certainly, they were worried, and we were worried about an angioinvasive fungal infection. And with more discrete appearance like this, and you can see it almost looks like it's got that peripheral higher attenuation like an infarct. Thought maybe something like mucor. They actually did a bronch, and they grew out some rhizopus species, which I guess is a zygomycete. It didn't get better over the course of a few different studies. And you can see this was a few days later. This was a few days after that. And still have this more round discrete lesion and then some surrounding areas of ground glass and consolidation, largely confined to the left lower lobe. So she went to lobectomy, and they confirmed that this was a fungal infection right in this area. And they described it as more of a spherical thing and then surrounding areas of ground glass and consolidation. So left lower lobectomy, and then the story, we revisit her. She relapses again, comes back in. So in the interim, her lungs look reasonable other than the underlying abnormal airways. This is now June. Then comes in July, neutropenic fever again. And Howard, I know you in particular, you'll like this next case. This is what she looks like on July 23rd. Just has a little nondescript area of consolidation centrally in the right upper lobe. Not really much you can say about that other than it certainly would be a focus of infection. And really, I don't know what organism. But check out what happens over the course of 6 days. You'll see now that this has really blossomed into this huge area of lobar consolidation. She also has these small effusions bilaterally, but look at her interlobular septae here on the right. She has all of these venous lakes or the lymphatic pearls, the little sausage links, and they developed rapidly over the course of a few days. Now, she had a bronch, and the bronch was positive for aspergillus, but it was uncertain. I don't know how much of this is aspergillus. I think a lot of this is probably just going to be venous congestion or asymmetric edema, because you'll see on her subsequent radiograph, even just a couple days later, that you can still see some of this septal thickening. But by a week later, this whole area has substantially improved. So I don't know. You think this is asymmetric edema? Her pulmonary veins weren't compromised in this area, and she had just effusions elsewhere, but no other areas. Maybe a little bit of septal thickening on the left, and not really much in the right lower lobe. But I don't know. How would you explain this appearance?
I don't know. I was starting to think of pulmonary veins, but now I don't know. It's a very dramatic interstitial edema. The question is why.
And of course, I don't know. Maybe I just never was seeing these, but until you mentioned the presence of the venous lakes a few years ago, or the lymphatic pearls, I was not that cognizant of them. But we see them now pretty frequently with edema, and I don't think this is lymphangitic spread of her leukemia lymphoma or anything, because it was too rapid, and there's too many other findings of edema, too many areas that are smooth septal thickening, and it just got better so rapidly just with antifungals and diuresis. So
very strange.
On the CT with the proper window, you can see that the pulmonary veins are not compromised centrally. Yeah,
here's the superior pulmonary vein right here.
Mm-hmm.
And Yeah, and it looks like it's fine.
Yep.
Yeah.
Well, I think, the best guess then, if the veins are okay, is that it must have just blocked all the lymphatics, all that swelling around the right hilum, probably just completely obstructed lymphatics, and it's just backing up. That would also predispose to the pleural effusion. So
Yeah.
lots of inflammation and probably lymphatic compromise, but it's pretty fair.
Yeah, and she has a small left effusion too, and I think she was being hydrated on chemo and such. So, but I don't know if it's just an asymmetric edema in addition to her having the pneumonia, but just really quite a dramatic case.
And her, she didn't have mitral regurg or anything like that. I mean, she's 61.
No, I don't know. Her heart is okay. There was no acute MI with papillary muscle rupture or any other cause of mitral regurg.
Got it.
So yeah.
On that follow-up, the lobar edema interstitial is still conspicuous. It's just such a lobar process.
Yeah, a little bit. Yeah. So she's actually scheduled to get a follow-up CT this week. This was now just over a week ago, but I thought you'd like this because it's just so profound.
Mm-hmm. Yeah, it is.
So
it's a pearl.
Lots of pearls. So
we
will, and then this was just the report. So the first one was Rhizopus. I don't know, David, you're the microbiology expert here.
That's a new one for me.
Yeah, but it is of the zygomycete family.
Right.
So.
Yeah.
Okay. Well, thank you guys very much, and we will reconvene next week.
Right. Bye, everyone.
Right, take care. Bye.
Bye, everyone. Thank you very much. Bye. Thank you. Bye.